Now, if you have any questions in terms of our products or ANTG, please do not hesitate to reach out. These are our contact details. So then now I can pass it on to you, Teresa.
Okay, thank you very much, Beatriz. So my name is Dr. Teresa Towpick, and I am the co-founder medical director of Medihuanna. And Medihuanna is a CPD-approved education provider. So you will be able to claim 1 hour of CPD 1 hour by contacting your relevant CPD home. So once again, thank you very much, Beatriz and ANTG for inviting me here today. And thank you all for joining us to listen to my presentation. Now, just a couple of housekeeping points. It is absolutely essential that and important for me that everyone stays muted, so we avoid any unwanted background noises. And also, I prefer to be uninterrupted during this presentation because there is a lot of material to cover, even short period of time. But I encourage you to start posting your question in the chat. Make sure that the question is directed to everyone. So hopefully we'll have a bit of a time at the end of presentation to answer your question. I understand that majority of you are new to medicinal cannabis, so I hope it will be a good introduction for you. For the ones who are experienced prescribers, perhaps it will be just a nice way of reviewing this information. Also, Medihuanna is running regular workshops. We have online courses as well, so you can expand your knowledge about medicinal cannabis too. Before I start my formal presentation, I also want to share the Medihuanna community, which we are very, very excited about this initiative. We've got over 3,000 members now in our community, so you can join that community as well, which is very, very useful, and in particular, Medicinal Cannabis Forum, where you can, when you go what's on your mind, you can just post any question. And we've got great engagement here, lots of good questions, relevant questions, and anything, and a lot of interaction here. So this is a community of like-minded doctors, and we are sharing our knowledge and experience and so on. We also have recording of previous workshops. We're running a series, usually on a fortnightly basis. We are running webinars with guest speakers. So here is the list of the webinars we've already done. And being a member of the community, you can go to these webinars and just they are all recorded and available here. And also now on 10th of May, we will have the webinar, which is next week, the treatment of anxiety and depression with medicinal cannabis by Professor Kyle O'Brien, Dr. Mihindu Jayasuriya. Then on 20th of May, we have an overseas speaker, Mara Gordon from Los Angeles, who will talk about cannabis treatment protocols and varieties of medication. And then on the 31st of May, we have Dr. Jamie Rickle, who will talk about the endocannabinoid system, stress responses, and homeostasis. So we are very, very excited about this initiative, and we are delivering a lot of useful education. So now I'm just going to start my presentation. Okay, I need to share. Okay, good. Everyone can see my screen, all good? So anyway, so today the topic is medicinal cannabis essentials. So I'm just going, this is such a complex area of medicine now. There's a lot of information, so it's a little bit difficult to provide everything within a short period of time, but I will do my best. So I'm going to begin with the endocannabinoid system, because this is such a very, very important homeostatic system in the human body. That system was unraveled by scientists over 30 years ago in what is now considered by many as the main discovery in human biology. However, majority of doctors, including myself, until 2016, never knew about it, and it is not part of medical curriculum, curriculum in medical school. So the endocannabinoid system was named after the cannabis plant, and it is the universal, omnipresent system responsible for internal regulation, cellular communication, and homeostasis. So that system is a modulatory regulatory system. And it plays a very important role in establishing and maintaining human health. And the endocannabinoid system is present in humans, animals, and plants alike, except it is not present in insects. And it is believed that this system originated over 500 million years ago and kept on evolving. So the three main components of the endocannabinoid system are endocannabinoids, which are molecules internally produced in our bodies, anandamide and 2-AG. We also have cannabinoid receptors, CB1 and CB2. And the third part is enzymes, enzymes involved in the synthesis of endocannabinoids. But I'm focusing here on, just for simplicity of the presentation, I'm focusing on degrading enzymes, which is FAAH, fatty acid amide hydrolase, which is responsible for degradation of anandamide, and MAG, monoacid glycerol lipase, which is responsible for degradation of 2-AG. And so I'm just briefly going to describe all the components of the endocannabinoid system. So cannabinoid receptors CB1 and CB2 were cloned in the early 90s, CB1 in 91 and CB2 in 93. Our bodies are densely populated by these receptors, and they are present on the surface of the cellular membranes, and they in the CNS, in the presynaptic neurons, and they belong to the family of G protein coupled receptors. So the CB1 receptors are predominantly found in the nervous system, mostly in the brain and the spinal cord. Our brains are densely populated by these receptors. The CB1 receptors are 10 times more present in the brain than opioid receptors. But what is very interesting, that there are very low densities of CB1 receptors in the brainstem, particularly cardiorespiratory receptors, which probably explains why there's so far no evidence of lethal medicinal cannabis overdose. Obviously, some cases might be circumstantial. And CB1 receptors are also present peripherally on peripheral nerve terminals in the liver, spleen, testes, uterus, breast tissue, endocrine, exocrine glands, and so on. So CB2 receptors are predominantly found in the immune system, highlighting the possibility that endocannabinoid system has immunomodulatory role. And now scientists believe that CB2 receptors are involved in the pharmacological effects of cannabinoids on immune system and inflammation. Now, also following cloning of the CB1 receptors, further research led to discovery of our own endocannabinoids and all endogenous cannabinoids. And today, the two well-established endocannabinoids are anandamide, also quite often referred to as bliss molecule, and it was named after the Sanskrit word ananda, meaning supreme bliss, happiness, and joy. 2-AG, 2-aragonol glycerol, is present in the brain at concentration 170 times higher than that of anandamide. And anandamide is partial agonist to both CB1 and CB2 receptors, with higher affinity to CB1 receptors, and 2-AG is full agonist to both CB1 and CB2 receptors. So this is the summary of the features of the endocannabinoids. They play a crucial role in bioregulation, main role in cell signaling. They are of lipid structure, making them lipophilic. They're hydrophobic. They're involved in local cell signaling, paracrine or autocrine. They are retrograde neurotransmitters in the brain. They form from the internal lipid constituents on the cellular membrane, synthesized on demand and not stored, in contrast to classic neurotransmitters, and they characterize a very short half-life. So the endocannabinoid system is responsible for regulation of majority of physiological processes in the body, and that includes stress, emotion, memory, cognition, sleep, digestion, inflammation, thermoregulation, neurodevelopment, neuroprotection, movement, psychomotor behavior, pain, cardiovascular and immune function, metabolism, and appetite regulation. So in short, this system basically regulates how we eat, sleep, relax, forget, and protect, as summarized by Professor DiMarzo in 1998. And I just want to mention the theory, very important theory of cannabinoid deficiency syndrome, Some scientists now postulate that many medical conditions, especially the one related to immune system inflammation, might be due to the deficiency in the endocannabinoid system. It is possible that some individuals are making not enough or too many of endocannabinoids and receptors for the system to work efficiently and keeping everything in homeostasis. So deficiency in the endocannabinoid system has been implicated in the pathogenesis of many clinical conditions, including chronic pain, mental health disorders, the schizophrenia, inflammatory bowel disease, and many, many others. So let's go through some pharmacology. So cannabis has this ability to interact with the human bodies through the endocannabinoid system, CB1 and CB2. So most of the biological properties of endocannabinoids are due to the interaction with the endocannabinoid system. But cannabis also interacts with the human body by many other metabolic pathways, both through receptor and non-receptor mechanisms. So, but also we need to understand that cannabis can be considered as a multi-target drug and can be useful in the treatment of many complex and rare conditions because it interacts with so many systems apart from endocannabinoid system. So it might give us the ability to treat multiple symptoms and multiple conditions simultaneously. So thus it can give us ability to reduce the polypharmacy. However, due to entourage effect, it appears that medicinal cannabis works best as the whole plant medicine because every part of the plant is very, very important. So here is the concept that whole plant versus single molecule agent. As in the beginning of 20th century, the pharmaceutical companies began introducing single molecule synthetic agents, and we doctors were trained to rely on them as effective, reliable, evidence-based, and safe. However, this approach led to the development of quite significant polypharmacy. And when it comes to cannabis plant, there are many components here. We've got major cannabinoids, THC, CBD, minor cannabinoids, terpenes, and flavonoids. And every part of the plant is important, has the important therapeutic and modulatory effect. And according to entourage effect, single component working alone is not as effective as the whole working together. And so let's go through pharmacological effects of THC. So THC, delta-9 tetrahydrocannabinol, is the most abundant part of cannabis plant. It is responsible for its psychedelic effects, feeling of euphoria and sedation. But psychoactive effects is just part of story here. It is also a very important therapeutic molecule. And feeling of euphoria or sedation sometimes may be quite appropriate. It's not necessarily an adverse effect, especially when we talk about terminal, very sick cancer patient. You all agree that feeling euphoric is not adverse effect in this situation. And THC is produced within glandular trichomes, the highest concentration of which are on the unfertilized flowers of the female cannabis plant. So this important molecule was isolated in 1964 by Professor Mechoulen and his team. And THC interacts with human body mostly through CB1 and CB2 receptors. However, it also interacts to some degree with other systems as well. And it is a weak partial agonist to both CB1 and CB2 cannabinoid receptors. So the psychoactive effects of THC are due to activation of CB1 receptors in the brain. So activation of CB1 receptors in the neocortex might cause altered thinking, judgment, and sensation. In basal ganglia, slowed reaction time, in the hippocampus, altered short-term memory, in cerebellum, impaired coordination, in spinal cord, altered pain sensation. In the brainstem, it might have antiemetic effects. In hypothalamus, appetite stimulation. In amygdala, activation of CB1 receptors might cause sometimes panic and paranoia. In nucleus accumbens, sense of euphoria. However, THC also exerts important therapeutic properties. This is very basic and short list here. The analgesic effects of THC might be due to activation of CB1 and CB2 receptors at the level of peripheral nerves, spinal cord, and brain, which can modulate pain perception, nausea and vomiting due to activation of CB1 receptors in the brainstem, appetite stimulation due to activation of CB1 receptors in the hypothalamus. And THC also has important antioxidant properties. It is actually more potent antioxidant than vitamin C and E. THC might control seizures due to its ability to regulate neuronal excitability. However, more research is needed, and it's that is going through activation of CB1 receptors. Also, THC has important anti-inflammatory functions due to activation of CB1 and CB2 receptors, but also other contributions such as inhibition of PEG2 synthesis, reduced platelet aggregation, and stimulation of lipooxygenases. So let's talk about the CBD. CBD is the second most abundant, non-addictive, non-psychoactive part of cannabis plant, characterized by a very low level of toxicity. And this important molecule was first obtained from cannabis plant in 1940 by Roger Adams and his colleagues, and its molecular structure was then elucidated in 1963 by Professor Merchulian and his team. So CBD has very low affinity to CB1 receptors. Its affinity is 100 times less than THC, and this may underline its lack of reinforcing properties, and the finding that CBD didn't induce euphoria or intoxication in healthy volunteers. And so it's interacting with CB1 and CB2 receptors on the allosteric binding site and working as a allosteric, negative allosteric modulator. CBD has the ability, I'm just going to go briefly through proper function of CBD, lots of slides here, but I think the graphic presentation is quite important. So CBD, it's also called a promiscuous molecule because it interacts with so many systems. So it might modulate the psychoactive effects of THC, acting as a negative allosteric modulator of the CB1 receptor, and thus acting as a non-competitive antagonist to the ligands binding on the orthosteric site, such as THC and other agonists. The other possible mechanism of how THC modulates psychoactive effects of, how CBD modulates psychoactive effects of THC is inhibition of FAH. FAH is enzyme responsible for anandamide degradation, and as a result, anandamide level goes up, and then CB1 receptors are occupied for a longer period of time, thus preventing THC from binding to them. There's also another mechanism that CBD might inhibit first-pass hepatic metabolism of THC to be possibly more psychoactive 11-hydroxy-THC, thus prolonging its half-life and reducing associated psychoactive effects, panic, anxiety, and tachycardia. Now, the CBD interacts agonistically with TRPV1 receptor, thus might have an analgesic effect, and TRPBT is known to mediate pain perception, inflammation, and body temperature. Also, CBD might have anxiolytic antidepressant effects due to agonistic interaction with adenosine receptor and modulation of dopamine and glutamate. CBD also might regulate stress response and compulsive behavior due to agonistic interaction with 5-HT1A serotonergic receptors. Also, CBD is known for its anti-convulsant effects. There are many mechanisms how it happens. One of them is that CBD might increase the anandamide levels, which happens through inhibition of the FAH enzyme responsible for anandamide degradation. Recent evidence suggests that this inhibition happens by targeting these transporters. So, an anandamide is known to be neuroprotective and anticonvulsant. CBD may have anti-nausea and antiemetic effects due to indirect activation of somatodendric 5-HT1A receptors in the brainstem. And CBD might, there's evidence showing that the CBD might be useful in the treatment of addiction due to its ability to attenuate the mesolimbic reward system. CBD stimulates the 2-AG release, another endocannabinoid, which is involved in suppression of seizures, pain management, appetite regulation, and immune function. CBD also interacts antagonistically with GPR55 receptor, and by doing this, it can slow down the development of osteoporosis and cancer cell proliferation, and also inhibits expression of ID1 gene, which is associated with tumor growth. CBD also interacts agonistic with PPAS receptors, which are situated on the surface of the cellular nucleus, and these receptors are involved in the inflammation and anti-tumor effects. So as you can see, there's very, very busy molecule, and there are so many systems that it can interact with. But apart from major cannabinoids, THC and CBD, there are also hundreds of other cannabinoids, so called minor cannabinoids, and the ones that are well known, the examples of this are CBN cannabinol, CBC cannabichromine, CBG cannabigerol, THCV tetrahydrocannabivarin, and CBD cannabidivarin. There's also terpenes and flavonoids. So the minor cannabinoids have also important therapeutic effects such as anti-inflammatory, antidepressant, antibacterial, antiviral, antifungal, anti-tumor, appetite stimulate, analgesic, and neuroprotective. So also terpenes and flavonoids play an important role in the cannabis plant. They are synthesized inside the secretory cells inside the glandular trichomes. And for example, limonene is known for its antidepressant immune stimulating properties. Myrcene is analgesic and sedating. Pinene might alleviate short-term memory impairment caused by THC. Beta-caryophyllene, very interesting molecule. It's known for its anti-inflammatory, analgesic effects, cytoprotective in the stomach, and it is also selective full agonist of CB2 receptor. So the therapeutic properties of cannabinoids in general, this is quite the list is quite short. There's much more than that, but just the examples of that include analgesia, muscle relaxation, immunosuppression, anti-inflammation, anti-allergic effects, sedation, improvement of mood, stimulation of appetite, anti-emesis, lowering of intraocular pressure, bronchodilation, and neuroprotection. So this is just a short list taken from the SASB, from TGA. Of course, the list is much, much longer, but the common example of clinical application of medicinal cannabis include chronic non-cancer pain symptom management, neuropathic pain, fibromyalgia, migraine, chemotherapy-induced nausea and vomiting, refractory nausea and vomiting, palliative care, multiple sclerosis, spasticity, seizure management, PTSD, insomnia, anxiety, anorexia, dementia, dystonia, Parkinson's disease, Huntington's disease, Tourette syndrome, and many, many others. So let's talk about the acute toxicity and safety ratio of medicinal cannabis. So the medicinal cannabis products are generally considered to have a very low level of toxicity. They are very, very safe. However, at the same time, we need to be mindful when we are titrating and dosing medicinal cannabis that higher doses, especially the products containing THC, may increase the possibility of the adverse effects. But at the same time, THC, the estimated median lethal dose of THC is more than 800 milligrams per kilo. So it will be very, very extremely difficult to reach that dose, and then practically impossible. And CBD, on the other hand, appears to be safely tolerated by humans, and doses as high as 1,000 milligrams per day or more in epileptic patients have been safely tolerated. So I'm just going to explain the safety ratio of THC. This is the ratio between estimated therapeutic dose and lethal dose. This is based on the study conducted by Robert Gable, in which a range of psychoactive substances were compared. And with regards to THC, the result measured the average therapeutic dose of THC 15 milligram and the possible lethal dose 15 gram, meaning that one would have to consume 1,000 consecutive doses to reach the lethal dose, which practically impossible to achieve. But by comparison, the safety ratio of codeine commonly prescribed for chronic pain is the 120, meaning that the usual therapeutic dose is 40 milligram, estimated lethal dose is 800 milligram. So the person would only need to consume 20 consecutive doses to reach the lethal dose. And I just wanted to show you the graph about the acute lethal toxicity. So the most lethal is heroin. 6 consecutive doses will you reach the lethal effect. But when it comes to cannabis, magic mushroom, LSD, they are right at the bottom with you need to consume 1,000 consecutive doses. But when I look at this graph, I always find it fascinating that LSD, magic mushrooms, cannabis, the most safe psychoactive substances, the safest. At the same time, they've been so stigmatized and considered as very dangerous. So you can see by the graph that it is, and again, based on Robert Gable's study, that this is not the situation. And when you think caffeine is actually more dangerous, 50 consecutive doses, codeine only 20 consecutive doses, alcohol only 10, and so on. So medicinal cannabis appears to be very, very safe. And also just drug-induced another cause of death, 2012, long time ago. So lung cancer was #1. And this year, there were no reported cases due to cannabis overdose. So what are the possible adverse effects? Most of the time, in my experience, medicinal cannabis is well tolerated. Sometimes it may cause a bit of drowsiness, fatigue, dizziness, dry mouth, cough and bronchitis, smoking, which of course is not recommended, anxiety, nausea, and cognitive effects. It may cause diarrhea, euphoria, blurred vision, headache, and very rarely orthostatic hypotension, toxic psychosis, depression, ataxia, coordination, tachycardia. But also remember that these adverse effects are mitigated when medicinal cannabis is used responsibly, judiciously in a proper clinical setting, when we are sticking to the mantra, start low, go slow, and we are using the smallest possible doses to achieve a maximal therapeutic effect with minimal or no adverse effects. And the long-term effects of cannabis may include lowering IQ, memory, cognition, developing brains, which of course we don't recommend it to healthy teenagers. It may cause impaired concentration, memory, and learning. Very rarely drug-induced psychosis. It may cause hormone imbalance. As I mentioned, smoking of cannabis might cause respiratory effects such as sore throat, bronchial irritation, excessive phlegm, and wheezing, which of course is not recommended. Very rarely, for heavy and regular users of cannabis, they may experience cannabinoid hyperemesis syndrome, characterized by episodes of nausea, vomiting, and frequent bathing. Also, regular higher doses of cannabis may lead to cannabis use disorder. So what are the contraindications? Not so many. Cannabis is generally well tolerated by majority of people. Of course, we are not going to prescribe it to pregnant or lactating women because we don't really know the effects on cannabis on developing fetus or young children. And this is very important when you are prescribing for women in reproductive age. Make sure that you give them advice on contraception because you don't want them to experience unwanted, unplanned pregnancy while taking medicinal cannabis. And also history of psychosis in the past. However, it is not an absolute contraindication. It all depends on the clinical situation, and CBD products can be safely used. But it all depends on your assessment and clinical situation as well. So caution needs to be exercised in unstable cardiac conditions, especially with products containing THC, because THC may cause hypotension and arrhythmias. Also, use in children and adolescents is debatable. You have to make sure that possible benefits will outweigh possible risk. Possibility of addiction and dependence. Of course, smoking is not recommended, in particular people for COPD and asthma. But just with physical dependence with addiction potential. So here is the scale taking from Independent Committee on Drugs in UK. So heroin is most addictive, #1, it is rated as free. But when you look at cannabis, it is #15 and addiction potential is 0.8. So there's a possibility of addiction, but it's very low. And especially with medicinal cannabis, we're talking about two different things. We are not talking about recreational cannabis. With medicinal cannabis, the possibility of addiction is extremely low, especially when we are monitoring this patient and making sure that we're using smaller possible doses. So potential drug interactions. And before commencing with any treatment, it is important that we understand potential drug interaction associated with exogenous cannabinoids, because a lot of these people coming to us for the prescription present with a huge polypharmacy as well. So the drug interaction with cannabis are mainly associated with simultaneous use of other CNS depressants, and cannabis has additive CNS depressants effect when combined with alcohol, barbiturate, and benzodiazepines. Also, we need to be careful, mindful, especially in the beginning, for patients when warfarin, because THC and CBD may increase anticoagulant effect of warfarin. So especially in the beginning, in titration process, it is important that we are regularly checking the INRs. Cannabis is metabolized in the liver using cytochrome P450 enzyme, which is responsible for metabolism of majority prescribed drugs. And however, drug interactions are generally low risk. This is more of a theoretical consideration. And more of a theoretical consideration. I've seen patients on huge polypharmacy, so we don't need to stop all the medication. It's okay to start medicinal cannabis using smallest possible doses, and then gradually, as patient symptoms are better controlled, then we can start slowly and carefully reduce other medication. And we can see that patients who are using medicinal cannabis, this is clinical observation, that a lot of them are able to reduce or even stop the other medications, whereas before it wasn't that easy. So how we determine suitability for medicinal cannabis? So at this stage in Australia, cannabis can be considered when other medications fail. And so at this stage, it's not a first-line treatment, it is a second-line treatment. However, and we need to assess our patient on a case-by-case basis. However, recently TJ relaxed its position here. So it's not that you have to force patients to use other medication like opioids or benzos and so on. What you need to do, you need to discuss it. So in your history, in your notes, you say that conventional treatments were discussed and suggested to a patient. And if a patient is reluctant to go ahead with that, it's absolutely fine to prescribe medicinal cannabis. You just need to consider other medication. Before, we have to show and demonstrate that they tried and they failed. So also it's very important that we document previous treatment history and all the medicine use, and once again conduct risk to benefit analysis, making sure that benefit outweigh the possible risk. And what is happening in initial consultation. So we need to remember that, to me, medicinal cannabis is an ultimate personalized, individualized medicine. So in this situation, one size fits all is not going to work, because everyone, due to different differences in the endocannabinoid tone among different patients. So we need to treat each patient very individually. And I think it's also very, very important that we see the patient, the human being in front of us, not just a clinical condition of a symptom, chronic pain, epilepsy, or anything else. And it is very important to communicate the cost, because even prices are going down, but medicinal cannabis is still quite expensive. We need to talk about therapeutic effects, safety issues, adverse effects, advice on driving, but also it's very, very important to address patient expectations, because quite often they might be quite overinflated. They think that it's a miracle drug that will fix them straight away, which is not the case. We need to outline to them that it's expensive, it takes time, the titration is slow, and the results may not be imminent. The more you communicate in this first initial consultation, the better off you are. So, and talk to the patient, ask them, what do you really expect? What is going on? And that's very important. So you need to take a detailed history of the symptom, underlying diagnosis, past medical history, history of mental illnesses, family history, including mental health, medication review, allergy history, history of drug dependence, substance abuse disorder, social history. So the employment, make sure that you need to, if they are operating heavy machinery, taxi drivers, Uber drivers, and so on, policemen, you really can't prescribe THC to them. So the advice on driving is important here as well. And if you feel it would be appropriate to consider consulting patients with your colleagues and go through baseline assessment, it's good to have some assessment scores, for example, numerical pain scale, symptoms assessment scale, measure quality of life, clinical examination as appropriate. And then we discuss different cannabis-based products, and that choice will depend on age, medical condition, previous cannabis exposure, familiarity with medicinal cannabis, and required cannabinoid ratios. So it's very important that you maintain appropriate documentation, and you need to sign the consent form to medical treatment because it is still unapproved medicine. And we have a template in our Medihuanna portal. So let's talk now about delivery methods. So medicinal cannabis can be delivered by many ways, and the choice will depend on patient age, clinical condition, familiarity. So that could be oral, sublingual, inhalation, topical, rectal, vaginal, juicing. The most common will be oral. Also, we have some sublingual, inhalation, topical products. Rectal, vaginal are not that common. Juicing is not really possible at this stage because people would need to grow their own plants, which is illegal at this stage. But wherever possible, the benefit of juicing of raw cannabis are quite significant, especially for patients with inflammatory bowel disease. Cannabinoids have important therapeutic properties in the raw form, and they are not psychoactive because they require heating through the process of decarboxylation to become psychoactive. Okay, so medicinal cannabis oil delivered orally are the most common way of delivery method in Australia. They are characterized by onset within 30 to 90 minutes, peak effects within 2 to 4 hours, duration between 4 to 12 hours. And I've seen patients even lasting 24 hours. Bioavailability varies between 10 to 20%. Smoking inhalation method is, of course, it's not recommended because combustion of smoke at high temperatures between 600 to 900 degrees can create toxic byproducts and also cause respiratory problems. And on top of that, it is a very inefficient way of delivery because 30 to 50% of cannabinoids are incinerated. Vaping offers a more efficient cannabinoid extraction. This process heats cannabis at 160 to 230 degrees. Toxic elements are significantly reduced but not completely eliminated, and patients also report less respiratory symptoms. So the advantage of inhalation method is rapid onset of action within minutes, the peak effect within 30 minutes, duration of action between 2 to 4 hours, and bioavailability varies between 2 to 56%. And it depends on the depth of inhalation, duration of breath holding, and temperature of vaporizer. So it's quite a lot of variability here. Let's talk about cannabis dosing. So for the ones interested in prescribing, I always recommend this article, which was posted in 2018 in the European Journal of Internal Medicine, Practical Consideration in Medical Cannabis Administration Dosing by McCallum and Russo. And I found it very useful and practical, so I recommend that everyone should read it. And we have access to this article in our Medihuanna portal. So according to McCallum and Russo, for products that contain THC, the dosing is dependent on the amount of THC in this product, because this is the part that is responsible for most side effects, such as fatigue, tachycardia, dizziness, and always remember start low. So the maximum daily dose of THC, it is recommended that it shouldn't exceed more than 40 milligrams per day. However, that doesn't mean that you can't go above the dose. Some patients might be more tolerant to THC and they might require higher doses. However, in my experience, it doesn't happen very often, especially when you are monitoring these patients, having regular follow-ups and teaching them and educating. So most of the time going more than 40 milligrams per day of THC doesn't really give us more therapeutic benefits, but may give us possibility of adverse effects. And there are many ways how you can sort of keep the dose down. CBD, on the other hand, as mentioned before, has been tolerated safely at doses as high as 1,000 milligrams per day. However, it is also very expensive, so we need to be mindful about dosing. Now, what we also recommend, this is a practical tip, cannabis holiday or titration break. When you're sort of reaching higher doses of THC, close to 30 or 40 milligrams, instead of going higher and higher, you may just stop cannabis for 2 or 3 days. And some clinicians recommend cannabis holiday regularly, at least 3 to 4 times per year, because what happens with cannabinoid receptors, they sort of become more avid. So we can regulate these cannabinoid receptors, and they become more avid for cannabinoids. They sort of restore themselves. And this is the graph which I taken from the webinar with Dr. Sunny Sulek. So I just want you to focus on the graph, because it just shows us that going higher and higher with medicinal cannabis, especially product containing THC, is not good. It can be quite counterproductive. So here the horizontal line is the dose, and the vertical line is benefit. So here we've got lower dose, benefit is sort of low, and then it keeps on going up as we increase the dose. And here we've reached the optimal dose. However, if you keep on increasing the dose, going higher and higher, because patient may think, oh, it's not working anymore, we need more, then you go higher and higher, but the benefit goes down. And then you may have patients saying, oh, it doesn't work for me, this dose, I need to have 50, 60, 70. Don't do this. And you can even draw this graph to your patients, and you just tell them, actually, you need to do the opposite. You need to take a titration break, make your cannabinoid receptors restore themselves and become more avid for the cannabinoids. So just even explaining this to patients, especially ones who are demanding higher and higher doses of THC, can be quite educational and very worthwhile doing this. So initial dose and titration. So for products that contain THC, it is recommended that initial dose of THC is 2.5 milligram, preferably started at night, and half of a dose for cannabis naive or elderly patients. So if you have product 10 milligram of THC to 10 milligram of CBD, that initial dose in meals will be 0.25. And then we just titrate every 4 to 5 days or every week, depending on your clinical situation, until you have the optimal therapeutic effects or adverse effects develop. So with regards to CBD, we know CBD usually require higher doses. However, because it is very expensive, I recommend to start at smaller doses, even though they're not going to be that therapeutically effective straight away. But we want to find so-called sweet spot where it is effective and minimal or no adverse effects. So what I would recommend 5 to 10 milligram, or you can start higher than that, maybe 20 milligram, and then titrate every 4 to 5 days. You'd want to start going 50 milligram twice a day straight away, because it's very expensive, and you may miss that opportunity of using the smallest possible effective dose. And for pediatric epilepsy, it is from TGA, start 5 milligram per kilo per day in 2 divided doses. I don't have experience with pediatric epilepsy, but one who prescribe state that this is too high, just 1 milligram per kilo per day is enough. Also, you can watch our webinar. Now, we have recently webinar with a very famous cannabis clinician from LA, Dr. Bonnie Goldstein, who is very experienced in pediatric epilepsy. So you can watch this webinar and to see her approach. And then you just titrate by amount daily to 20 milligram per kilo per day at weekly intervals. Maximum recommended dose is 1 gram per day, but I wouldn't start at 5 milligram. Personally, I would start lower than that, 1 milligram. So for inhalation methods, it is recommended 1 inhalation, wait 15 minutes, and then followed by every 15 to 30 minutes until desired symptom control. Now, maximal daily dose, there's a bit of a confusion here, but I believe it should be based on the weight of the flower, not the amount of THC in the flower, because it's basically impossible to really find out how much exactly THC patients are taking for inhalation, because bioavailability could be so variable. So for low CBD, high THC product, the maximal daily dose should exceed 1 gram. And for high CBD, low THC, and balanced CBD THC products, it is 3 grams. So how to apply? Okay, I just go through schedule status. Are we going to come? Okay. So in December 2020, CBD was descheduled from Schedule 4 to Schedule 3, from prescription only to pharmacy only. So meaning that this product should become available over the counter of a daily dose 100 milligram per day for 30 days. However, these products are not, we can't buy them over the counter yet because they need to be registered on ANTG. And they are not products registered yet, so we still need to apply through TGA or authorized prescriber. So currently, so cannabis is still an unapproved drug, and only nabiximols and Epidiolex are the only cannabis-based products listed on the ANTG. Now, products, CBD products that contain more than 98% of CBD and less than 2% of other cannabinoids are Schedule 4, require TGA approval only. With THC, products containing any amount of THC, they are Schedule 8. But also CBD products that contain less than 98% of CBD are also Schedule 8. So they require TGA approval only, unless in New South Wales, patient is identified as a drug-dependent person, clinical trial, and a child under the age of 16. So there are lots of formulations available these days, and it could be very, very confusing. I believe there are, a few hundreds of products available, but they can be put into category like CBD products, CBD isolates and full spectrum CBD, low THC, high CBD, so CBD predominant, balanced products equal THC to CBD, and also products with high THC and low CBD. And with dry flower formulation, we also have CBD dominant strain that contain only small amount of THC, less than 1%, and various amounts of CBD. Also, we have balanced products, sort of having similar amounts of THC, CBD, and THC dominant with various amounts of THC. And so they also be indica, sativa, or hybrid. And with the access, with special access scheme category A and B, the most commonly used is category B, special access scheme B. Category A, I never use it, so I'm not very familiar with it. It's too complicated. It's better category B, so much easier. And also you have authorized prescriber scheme. So this is the rate of approval is going higher and higher. And to apply for medicinal cannabis, you go to compliance.health.gov.au/. And there's also more information about categories and so on, but it's not enough time to go through all of that. So if you are interested in more information about the 5 categories and other the TGA information, you can access our online courses or enroll in our workshop as well. I am doing the workshop on 13th of May, Practical Skills in Prescribing Medicinal Cannabis, where you provide much more information. So that's just the summary of the process, how to go through SAS. So it is important that we follow up this patient. When we get approval, we see this patient, it's our opportunity to sort of, that they can ask more questions. It's good to give them written instruction about dosing and have this 1 ml at your desk and show them where actually they dose, because sometimes it's not unusual for them to confuse between 0.1 or 1 ml. You can handwrite the script, or there's also e-scripts these days. And you give patient, if you handwrite, you give patient the script together with approvals to be taken to the chemist. Some clinics have different routines about it. And also it's important, sometimes dispensing may take time. So it's good if patient will notify you when this product is dispensed, so you can start sort of document the start of treatment. And with writing, when you handwrite, it's important to write the usual patient's name and address, product name, cannabinoid ratio. Because now you can just write the category 1, 2, 3, and so on, but I wouldn't recommend it. I recommend that you write the specific product, because otherwise you may lose control of what is dispensed. And not every product is the same. Some of them may have different ratios of other cannabinoids, terpenes, and so on. So you write the cannabinoid ratio, concentration of cannabinoids, quantity volume, dosing distraction. Now, initially, I wouldn't recommend to give patients repeats, only give them the amount that is necessary to come back, within a short period of time. Because if you give them too many repeats, they may disappear for 6 months and you lose control over the treatment. And then they may come back asking for repeats. You don't even know what's happening. I recommend that you authorize the repeats once you're confident that patient is stable, compliant, and so on, and then you authorize the repeats. But if you do that, you need to specify the interval, dispensing interval. So look after this patient, see them regularly, encourage them to keep the record of the symptoms, any changes, do some assessments and so on. And follow up, I recommend to see them weekly until stable. And then you can see them, depending on the clinical situation, every 6 weeks initially. And then when they are really stable, you see them every 2 or 3 months, or further down the track when everything is going absolutely fine, even every 6 months. But also make sure that they see you if required, or you're available if required. And again, you use your different assessments, for example, numeric pain scale. Follow-up questionnaires, use any additional symptoms assessment, assess functionality, lifestyle. Functionality is very important. And it's not always very easy to measure, but for patients it means a lot. Because if someone wasn't able to do anything, was withdrawn, just not socializing and so on, and then they are able to even play with it, grandchildren in the park, it means quite a lot of them. With regards to blood tests, it's a good idea to know your initial blood tests, especially liver function tests. And if they are normal, then just repeat them in maybe 3 months. If there is some abnormality, repeat your liver function test a bit earlier, maybe in a month. Okay, so I've got some case studies now. Beatriz, it's 8 o'clock now. Would you like me to present this couple of case studies, and I can see there are some questions? What would we like to do?
Yeah, I think we'll probably go through the case studies, unless I think that will clarify quite a few of the questions that are being addressed on the chat. And once we finish with those, then we will answer those. So let me just very quickly go through the couple of case studies. So Kenneth is the patient who presented to me with chronic abdominal pain secondary to Crohn's disease and lower back pain secondary to lumbar spondylosis. Okay, so here is his medical history. 60 years old, was referred to me by his gastroenterologist, as quite often specialists. They're becoming more involved, but in the past they were supportive, but they didn't want to do the paperwork. So he presented with a long-term history of chronic abdominal pain secondary to ulcerative colitis, which was diagnosed many years ago. He experienced recurrent episode of abdominal pain, which was accompanied by PR bleeding, diarrhea, and mucus. He also suffered from chronic lower back pain secondary to lumbar spondylosis, no injury in the past. He had nocturnal pain resulting in insomnia. He would rate his pain around 7 on numerical pain scale, but frequently would go up to 10. His quality of life was quite poor. So with regards to past cannabis use, he has been smoking illicit cannabis as required for many years. And he stated that it was helping him, his both abdominal pain, lower back pain, as well. It was effective in stopping PR bleeding and diarrhea, and it helped him with insomnia. And on further questioning, he wasn't experienced withdrawal symptoms with smoking. So when you have a patient who presents to you and he or she is smoking illicit cannabis, it's always important to ask yourself a question. Is this patient abusing cannabis? Is there a possibility of cannabis use disorder? So it's good to ask them how many times per day, in a form, what form, cones, joints, bongs, and how often do you need to use it? And what does it do to you? And what happens if you don't use it? And how much does it cost you as well? And if you don't use it, what happens? If a patient tells you, oh, I just have a
a bit of a pain or anxiety, but it's more of a rebound. But if he tells you, oh, I can't live without it, I don't like it that much, but I have to use it because otherwise I have horrible symptoms. I'm sweating, I feel nauseous, I've got abdominal pain, body aches. So then you know that they're experiencing withdrawal symptoms, and then you need to treat it accordingly as well. And again, we have webinar on cannabis use disorder presented by Professor Nitzeli, so you can also watch it as well, how to treat it. So with social history, no smoking, alcohol occasionally on special occasions, no substance abuse, work as a cleaner, married, no children. So now other medical problems he had got: Barrett's esophagus, lumbar spondylosis, and erectile dysfunction. On examination, nothing really abnormal, not allergic to anything. So blood test essentially normal, just radiology, widespread degenerative disc disease on his lumbosacral CT scan. So we don't really have time to discuss all of these questions, but you can also ask yourself, what would be your initial impression, reflections? Do you have some kind of patients in your own practice? Are there any concerns that maybe some possible red flags? Would you be concerned about mental health? Any additional questions? So no history of psychosis in the past, no significant mental health disorders, maybe anything else in relation to his history. I will talk about his treatment in a moment. Family history. Would you be concerned about possible cannabis misuse? Would you ask him about the state of nutrition? Nutrition is very important because, as we know, diets could be pro-inflammatory, anti-inflammatory. How does he eat? Does he exercise? Does he meditate? How about his functionality? So, because you see, medicinal cannabis is not everything. It's important to also implement other ways of treatment. So here's treatments that he tried in the past: steroids called aggression, mood swings, acne, increased weight, and they were ineffective. Colophane was ineffective, mesosal ineffective, Nurofen ineffective and caused abdominal pain. Panadine Forte caused constipation. So also try some physio for his lower back, only temporary relief. Now, currently, not much. Paracetamol as required, Pentasa 1 gram per day, Somac 40 milligram, and Sildenafil 100 milligram as needed. So now another question. Would you add anything to his current treatment before you start medicinal cannabis? Would you order more investigations? Would you try to optimize his current management? Would you include advice on lifestyle? Would you now consider medicinal cannabis, and why? So I felt that he was eligible for medicinal cannabis because he tried other things which didn't work. And but also he was smoking. So it was also about harm minimization and making sure that he's guided by the doctor and not smoking illicit cannabis, which also smoking, we know, is not that good. And if you prescribe, what would you choose for this patient? Think if there is possible drug interactions, or are there any possible adverse of medicinal cannabis, and how would you manage them? So now this is the synopsis. We gave him a full spectrum balanced product, 10-10. And also we gave him dry flower for vaping, which was THC 40%, indica predominant. And we started him on 0.25, titrated on a weekly basis, and gradually got him to 1 ml at night and 0.5 in the morning over a period of over 1 month, plus vaping PRN. So what happened initially, sometimes it might be difficult for you to convince this patient to use all. We hear in our community discussions that some patients are reluctant, they just want flowers only, they would tell you that I can't tolerate all. But when you convince them, it could be quite beneficial. So patient reported significant pain reduction, level 1 and 2 on average, periods of no pain, improvement in PR bleeding, improved bowel motions, also improve in all GIT symptoms. He actually stated my Crohn's has never been better, improved sleep because of no nocturnal pain, improved mood, but also interestingly improved ED. And then the patient was actually grateful for recommending all. Although he was resistant in the beginning, he said, oh, I actually don't need to vape all that much, only vape hardly ever. But all appears to work much better for me. So I was very happy that I managed to convince him. Now we also have one more case study. This is a lady, Charlene, who presented with chronic non-cancer pain secondary to fibromyalgia, cervical and lumbar spondylosis. So Charlene 51 years old. She presented with chronic debilitating pain secondary to fibromyalgia, cervical and lumbar spondylosis. In 2007, she was diagnosed with nerve root compression in the lumbar spine, right side L3, L4, and spondylolisthesis L4, L5. She underwent L3, L4 discectomy in 2008. However, the procedure was not effective in reducing her chronic pain. She was diagnosed with fibromyalgia in 2009. She described a whole body pain, most severe in the neck and lower back, which was accompanied by electric shock-like sensation throughout the body. She suffered from insomnia secondary to nocturnal pain. Chronic pain affected every aspect of her life. She lost her job and she is now on disability pension, also lost her marriage, and she has been socially isolated. Her pain has severely impacted upon her quality of life and her mental health. She became very depressed and anxious, gained a lot of weight, became morbidly obese with a weight of 135 kilos at initial consultation, rated her pain very high, 8 or 9. On average, quality of life was poor. And she was previously attended NP and pain clinic. However, she stopped attending this clinic due to intolerable adverse effects from prescribed medications without pain alleviation. And then she has been under the care of rheumatologists at St. Vincent's Clinic in Darlinghurst, who provided a lot of endorsement. Never use cannabis in any form at all, so cannabis naive patients. That non-smoker, non-drinker, non-substance abuse, divorce, living alone, sickness benefit, pension, and not driving. God in the past, other medical problems, God, he had hysterectomy in the past due to heavily bleeding uterine fibroids. So on examination, grossly obese, 135 kilos, but also throughout the whole consultation, which lasted about 50 minutes, she was unable to sit at all. She was pacing around due to pain, and facial expression of patient who was really in a lot of pain. She had a limited range of movement in her lumbosacrospine, otherwise normal examination. She wasn't allergic to anything. So she had quite abnormal liver function tests, which were secondary to fatty liver. She was investigated, otherwise nothing significant. Her CT scan, widespread degenerative disc disease. So once again, if you think about this patient, could you relate to this case to any of your patients in your practice? Any concerns, any red flags, any additional questions about her mental health, family history, and also nutrition, exercise, meditation. So nutrition in her case was bad, a lot of biscuit and chocolate for pain. Quite often this patient tend to eat simple carbs just to have this sort of emotional comfort, as well as sort of, it provides them a little bit of analgesia, but then they become depressed and putting on weight. Functionality wasn't good at all. So this is her medication in the past, which caused adverse effects. Duloxetine, vomiting, pregabalin, she gained a lot of weight, tapentadol, worsening of tachycardia, nausea and dizziness, tramadol, nausea and nystagmus, nortriptyline hypes, and she tried all of these opioids, Velisli squad which caused worsening of tachycardia, nausea, uncontrolled vomiting and dizziness. So she was pretty stuck. Physio, chiro, remedial massage didn't really help her much. She also was seeing psychologists who specialize in living with chronic pain, so that gave her a bit of insight. On presentation, just Panadol PN. Occasionally, when she was very desperate, she used Medicinal Cannabis, but that would give her tachycardia. Also, she used pantoprazole, ranitidine, and vitamin D daily. So once again, knowing all of that, how would you manage this patient? Would you add any other investigation? How would you optimize it? Would you give advice on lifestyle? Would you consider medicinal cannabis now? Please justify. So I decided that she was eligible because she tried so much and she was pretty stuck. Treatment goals. Of course, when it comes to treatment goals, we want to improve their symptoms, improve their functionality, improve quality of life, reduce adverse medication. Now, what ratios of cannabinoids, any drug interaction, any possible adverse effects, and what would you do? So we actually applied initially for CBD predominant formulation. At the time it was 120, but there are also now different ratios that you can use, like 1:25, 1:50, and I think ANTG has product 1:50 with high amount of THC, which you can try. So I started her on 0.5 at night. We titrated every 5 days, but gradually she needed 2 meals 3 times per day over a period of 2 months. So it was quite a high volume and it was costing her a lot of money. So we switched her to balanced products 10 tails because of affordability. And she just takes 0.5 morning and night. So this is her response. Significant pain reduction, level 2 on average periods of no pain, improved sleep, no nocturnal pain, improved sleep. She started socializing, met a boyfriend. She commented on reduced brain fog, and what was really quite fascinating, but she lost 20 kilo in weight because she just said, I don't need to comfort anymore. I eat when I am hungry. And she started making better dietary choices. And interestingly, her liver function does have improved as well because of her significant weight loss. She started enjoying her craft of making various cuts, and some time ago, she sustained T11 superior end plate fracture, was admitted to local hospital, and her pain was actually well controlled with cannabis oil, which was administered by the hospital staff. And she refused all the other drugs, and her pain was really quite well controlled. So quite interesting and a fascinating case. So in conclusion, I'd like to say that, in my opinion, medicinal cannabis is a promising therapeutic agent in the treatment of many medical conditions, including chronic pain, especially when it is used in a proper clinical setting, guided by the doctor, using high-quality, standardized medicinal cannabis products. And then for further information about our work, you can write to us info@medihuanna.com. You can also visit our website, medihuanna.com, and our portal, My Medihuanna. I encourage you to join our community. And yeah, so thank you very much. I'm going to stop that share. That was really quite a bit of a race. I hope that I didn't be rushing too much, but I really wanted to cover as much as possible. But as I said, you will get more information, through further education, and we offer a lot at this stage. So I think we have some questions in the chat.
Yes, we do. We have a couple. Okay. So area applications being made for PBS listing to see if medicinal cannabis is PBS, or are there any clinical trials that companies are doing?
Okay, but so which question is it? I'm just looking up.
The first one regarding PBS by Bill Kefalas.
Okay, I think the first one was, are there any known risk of drug interactions?
Oh, yeah, you touched on that one. Sorry, skipped it.
Okay, so we talked about it already. So look, drug interactions are really more theoretical considerations. They are very, very low risk. And you can I've seen patients of taking 10 to 15, 20 different medications. I would start them on small dose of medicinal cannabis, and they were it was easier for us to reduce other medication, especially when they started feeling better. Okay, all right, so I'm just going down.
The next one is whether medicinal cannabis is going to be PBS listed soon.
I don't think it's going to happen very soon, which would be great, because I think medicinal cannabis could offer us substantial healthcare cost saving as patient become more functional, they can go back to work, we can reduce unnecessary hospital admission if we treat these patients better in the community. But I'm optimistic. I think it might happen within the next 5 years. But there's a complex process before the medication are listed on PBS. Now we have problems on listing our CBD products on ANTG. Even the CBD products were descheduled, almost 2.5 years ago now, almost 3 years ago soon, and we don't see them over the counter. So can you imagine going on PBS? But hopefully, these things happen quantum leaps. Nothing happens, and all of a sudden, floodgates open. So maybe politicians will wake up to themselves and see the possibility.
Well, just to add, we are investing, as I mentioned at the beginning of this call, on research in our company. So our aim is to list these products, register them, and then have them available under PBS. Of course, as Teresa mentioned, this is not a very quick process. So we probably have a couple of years more to get through it. Our IBS trial is probably coming to fruition next year. So fingers crossed, and we'll have something on the pipeline. But at the moment, none of them are under
And
PBS,
it's not
unfortunately.
very easy. Some companies, there are a few failed trials of CBD on insomnia, and so it's not that easy. But hopefully, things will happen. It's a complex process.
Yeah.
And I think also Bill asked, do health funds rebate the cost through pharmaceutical extras cover? So look, some health funds offer some rebates, but most of the companies offer some compassionate access as well. Does ANTG do that, Beatriz?
Yes, so we are listed, and if you talk to your health fund, there will be a rebate on our products. Some health funds will cover a little bit more than others, so it depends on who the patient is with. And in terms of compassionate access, we normally touch base with the doctors, and if they have particular patients that they need to access the medicine to a discounted price, or need to access particular bottles or jars of products, we make them available to them under certain conditions, basically. So there's also, our products are also been approved under DVA. So if you have a patient that has the gold card, if you go through the process, is the normal DVA process with quite a few forms, but we can facilitate all of that. If you're interested in going through the process, we can help you with the letters and paperwork that you need to present.
Thank you. And this, we're going to have a question for chronic non-cancer pain. How long do you think, in your experience, evidence that the patient will be on cannabis? Is it just replacing opioids or other pain meds, or can you come off cannabis in long run? That's a very good question. Thank you very much. So look, most of this chronic pain patients, especially with debilitating pain, they stay on opioids and a cocktail of the heavy drugs, which affect the functionality and make it don't really fully control symptoms. Basically, they can never get off. Most of the time, they never get off of that medication. So I believe that medicinal cannabis is better alternative. It could be just a replacement for opioids, benzos, and other things, but in my opinion, it is much better alternative. Patients are able to reduce their other medication or even stop. They become more functional. They become more motivated as well. But also another thought. This is just a theory. If we accept the theory of endocannabinoid system deficiency responsible, for example, for chronic pain, so perhaps theoretically at some stage that endocannabinoid system, tone might be improved and sufficient that perhaps we might end up using much smaller dose of medicinal cannabis, or eventually perhaps even stop it. Also, I want to say that endocannabinoid system can be improved not only with cannabinoids, but also lifestyle is important. The evidence shows that, for example, food rich in omega-3, omega-6 can improve endocannabinoid tone, because the body is using these molecules to produce endocannabinoids. Also, exercise can improve endocannabinoids, and mindfulness, breathing exercise. So I always used to tell my patients, if you just use cannabis and nothing else, and you still drink, smoke, and all of these kind of things, this is just another drug. So I always highly encourage doctors to, use all the other modality treatments, non-pharmacological as well. It's about empowering patients so they start relying on this drug so much. But once again, maybe you can try after some period of time, but not straight away. Don't rush into that. It's hard to define what period of time, maybe after 12 months, they're well controlled, they're functional, and so on. Then you can ask them, look, how about if we slightly reduce the dose, see if you are still functioning okay on a smaller dose. And you can try to see how it goes. At the moment, medicinal cannabis is quite new to us. So I think in the next few years, we'll know more about it. But I still believe, even if this is replacement for opioids, it's much better to use the medication. That one medicine can do so much because it has so many interactions with so many systems. If you just take Panadol, Panadol is most probably not going to improve your functionality. It's not going to improve your sleep. It's not going to, make you reach for better dietary choices and so on. So I feel even if this is just an ongoing replacement, is better option than opioids, benzos, and other things that people are not functioning and they are usually quite miserable.
Yeah, especially as you have patients probably that are on high dosages of opioids regularly, or they have been during a period of time of at least 6 months. Those are the patients that you might want to consider moving on to medicinal cannabis or adding medicinal cannabis into it, as there's some research that backs up the reduction of opioids over time once medicinal cannabis has been added into their into the treatment. Thanks, Teresa. That's very good.
And what should we say to patients who have sourced CBD online from overseas? Look, it's not recommended because the only legal source is going through from TGA, from the local supplies and stuff like that. Plus, the products online can, they not be even CBD. You can't really guarantee the quality there, and there are some warnings that some CBD products online may not be of high quality, may not contain that much of CBD what states there, and basically the only legal way to obtain CBD products is through the TGA, SASB, or authorized prescriber, seeing the doctor. All the other sources are not even legal. Plus, they are not. There's no guarantee that they have a high quality product, which with the companies who distribute products here, that guarantee and consistency is always guaranteed.
Yeah, they're mostly probably not even manufactured under GMP. So if the CBD source online is pretty much illegal in Australia, and it shouldn't be encouraged at this stage.
That's right. Yeah.
Mm.
And Susan, yeah.
Sorry, no, I was gonna read the next question. They were asking about DVA subsidies, which is what we were discussing just now.
Yeah. So there's DVA schemes and stuff like that, so it is available. Next one.
Yeah. Is there any prescribing criteria or usage criteria
for this one before? How about its use in treating THC addiction?
Oh, there is that one.
It was to me. Sorry, it wasn't.
Okay.
So that's why you can see. So basically, we're talking about cannabis use disorder. And the way to treat it, these patients always present with opportunity. They could be challenging, demanding, and entitled, but at the same time, you can, minimize the harms. You can convince them to, sort of use cannabis more efficiently. So you take your history, ask them exactly how long have you been using, how many years, what is the exact, why do they use it, how many times per day, in what form, bongs, cones, joints, or anything like that. What happens if they don't have it? Because most of the patients really, they sort of recreational, but they quite often self-medicate themselves. So you need to ask these questions. Now, with regards to it, so Professor Lynn recommends there are different approaches. Some people claim that sometimes these patients might be still sensitive to oils and stuff like that, but it is recommended to use to sort of take them off that habit of smoking. First of all, you can explain the harms, which quite often people don't really worry too much, but you can ask them how much do you pay on the black market, and you can also show that curve, that I show you about the titration, that the more you use, the less effective it is. So that the titration break is very important. But Professor Lindsay is actually his recommendation is to start them on the opposite. Usually we want start low, go slow. But in this situation, because we're so used to high amount of THC, he starts them on about 60 to 70 milligram of THC, but in the oral form, preferably balanced. For example, THC 10 to CBD 10 in a balanced way. And then for breakthrough, vaping is recommended. So you would stabilize them. You also give them advice on lifestyle and mental health counseling, maybe get the psychologist involved. And if you feel that it's too difficult, also get addiction specialist who is dealing with cannabis, like, for example, Professor Lynn Series. So you start them on a higher dose of THC, and then as they feel better, and especially not smoking, and then gradually you may start reducing the dose. So these patients might be challenging, might be difficult, but it's always a good idea to treat them anyway and get the advice of your colleague or addiction specialist. All right, so next one, Beatriz. Oh, you muted.
Yep. Yes, sorry. For chronic non-cancer pain, how long do you think in your experience evidence that the patient will be on that we got that one?
So any prescribing criteria?
Yeah. Is there any prescribing criteria or usage criteria for the different cannabinoid items for an individual patient, like oils, flower, all those types?
Absolutely. So every patient is different. So my criteria would be, we want to have some kind of system. So when you see the patient, ask, is it cannabis naive or is it cannabis experienced patient? With someone who is cannabis, we know that, for example, someone may come with a chronic, non-cancer pain. We know that balanced products are better than, we need both THC and CBD, but we don't know how this patient might respond to THC, because THC is known for its bidirectional effects. Could be anxiolytic or anxiogenic, depending on the patient. So if someone never used cannabis in the past, elderly people, you may start perhaps with CBD predominant product, like, for example, CBD 150 or 120 or anything like that. And then gradually they may respond to this product. They might be quite okay, but they may require a bit more THC. So then gradually you can move up to the content with more THC. With the flower, my attitude is that flower should be reserved for breakthrough. I'm a bit concerned that apparently about 70% of market is flowers. So it kind of gives me the issue here. Are we having sort of hidden recreational market in this legal market? So I don't think that this is a good idea. But on the other hand, after listening to the webinar with Dustin Sulak from America, he also says that some patients genuinely may not be able to tolerate oil, and for them regular vaping might be okay. But then you will establish, when dealing with patient, you will decide, is this patient just trying to use flower for recreational use, or are they a genuine medical person who can't tolerate oil? And you will get the feeling, if this patient keeps on demanding different flowers, 6, 7 varieties, and changing all the time and going for higher doses, then you know that it's probably abusing. So it's very important you have a compassion and empathy, but also establish your boundaries. So very individual approach. There is no hard and fast rules. One size fits all is not going to work here. And also, at our community, in our forum, there's lots of interactions, doctors asking, oh, I've got this patient, this is happening, what do I do? And other doctors answering that. So I think it's very, very valuable. Okay.
Yeah, that was the last question for tonight.
All right, and we finish on time. Lovely.
Yes, 1 minute. There you go.
Thank you so much for sticking around. I really enjoyed this presentation. I hope you for the ones who never prescribed, that you will feel encouraged to become involved with medicinal cannabis. And there's lots of information and education available. And once again, thank you, Beatriz and ANTG, for involving here. And you have a beautiful evening.
Thanks, Teresa. Thank you, everyone, as well, for joining. Have a good night. And please, we'll send them an email with some information after this.
Thank you.
See you soon. Bye.